Welcome back to the Calgary Guide Video Series. Today we're going to be talking about distributive shock, pathogenesis, complications, and clinical findings. Before we begin, a reminder to support what we do here at the Calgary Guide by liking this video and subscribing to my channel. Thanks in advance. Now with distributive shock, I'm not really sure why it's called distributive shock. Be that as it may, this is a slide summarizing the pathogenesis, complications, and clinical findings of distributive shock. First, pancreatitis, anaphylaxis, and sepsis all result in systemic inflammation that increases the permeability of blood vessels, which results in the fluid in the blood vessels leaking out of the intravascular space and collecting in third spaces, such as the interstitial tissue of a patient's extremities, like hands and feet. That results in extremities being warm as opposed to cold with hypovolemic shock. In addition, the reduced intravascular volume also reduces the venous return to the heart, reducing the stroke volume and reducing cardiac output, which results in distributive shock. Another triad of causes of distributive shock are vasodilatory drugs, liver failure, and adrenal insufficiency. Vasodilatory drugs, such as nitroglycerin, anesthetics, and calcium channel blockers, cause vasodilation, both arteriolar and venous vasodilation, which in turn leads to distributive shock. Liver failure results in the reduced liver clearance of vasodilatory molecules, which results in vasodilation and distributive shock. And adrenal insufficiency means reduced cortisol levels in the body, resulting in the body's not being able to appropriately vasoconstrict blood vessels, since that is one of the main functions of cortisol. That ends up in vasodilation and distributive shock. Finally, neurogenic shock, which is an injury to the C or upper T-spine, results in sympathetic nerve connections below the lesion being disrupted. If the injury is above T4, vagal inhibition of heart rate becomes unopposed, which results in bradycardia, which, note, is only found in neurogenic shock, because typically the heart rate response with distributive shock is tachycardia. We'll get to why in a second. In neurogenic shock, when sympathetic nerve connections below the C-spine or T-spine lesion are disrupted, that reduces the sympathetically mediated constriction of smooth muscle around the blood vessels, resulting in vasodilation and distributive shock. Now, what distributive shock means basically is the reduced ability to perfuse tissues with blood. That comes about because of reduced cardiac output and vasodilation, which reduces the systemic vascular resistance of blood vessels. So, because one's blood pressure is equal to the cardiac output multiplied by the systemic vascular resistance, that results in a reduction of the patient's blood pressure. Reducing the patient's blood pressure will further reduce venous return to the heart, meaning that the heart has to pump faster to try to raise the cardiac output so as to maintain one's blood pressure, resulting in tachycardia. Reduced venous return to the heart also results in reduced pressure in the venous circulation, reducing the patient's jugular venous pulse, the JVP. Low systemic vascular resistance and low blood pressure also, of course, results in insufficient organ perfusion. In the brain, less cerebral blood flow results in cerebral hypoxia, which results in a progressively declining level of consciousness. In the heart, there's reduced coronary perfusion, which could lead to myocardial ischemia. In the kidneys, reduced blood flow to the kidneys results in renal ischemia, leading to acute tubular necrosis or acute kidney injury, resulting in kidney failure. Reduced blood flow to the kidneys also reduces the measured GFR, glomerular filtration rate, and that is actually the definition of renal failure. In addition, in terms of the clinical signs of reduced glomerular filtration rate, one can see an increase in the serum creatinine levels, measured in blood work, as well as a decrease in the volume of urine produced by the patient, otherwise known as oliguria. In all body tissues, the inadequate delivery of oxygen to the tissue results in increased lactic acid production, and combined with the reduced clearance of lactate by the kidneys, results in lactic acidosis. Finally, because systemic vascular resistance is low in distributive shock, and because blood vessel tone, the baseline level of constriction of smooth muscle around blood vessels, is what maintains the blood pressure in the arteries during diastole. Blood pressure will drop in a more exaggerated way during diastole, and that increases the difference between the systolic and diastolic blood pressures, resulting in bounding pulses felt by the clinician and an increase in pulse pressure, which is the difference between diastolic and systolic blood pressures. And that's all for distributive shock, its pathogenesis, complications, and clinical findings. Thanks for your attention, and if you'd like to join the thousands of people who support the Calgary Guide and our work, please like this video and subscribe to my channel. Thank you very much. See you in the next video.